Afternoon, everybody, and welcome to today's Ask the Expert session. Today's session is called Using Problem Solving and Root Cause Analysis for Competency Process Improvement. This is the second in the series of Ask the Expert sessions that we're holding this month with Kevin O'Connell. My name is PJ Houston. I'm a policy analyst here at the Council of State Governments Justice Center, and I'm joined by our expert, Kevin O'Connell, and my colleague, Mark Stovall. I'll just quickly turn it over to Kevin first to introduce himself.
Thank you very much, PJ. I thank you for taking some time this morning to, kind of hear, really kind of how, one, how do we think about one of the more complicated parts of, like, I would say the justice and mental health system, which is really competency and really people's ability to participate in their own defense. And so my background is a lot of it's in California, but really it's at the intersection of justice and mental health, and also I'm supporting a number of stepping up counties in California. And I think really my role in this is really to kind of like maybe give you all some perspective. So I've kind of seen, but really leverage your expertise from really doing the work or trying to do the work in so many different counties across the country. So thank you, PJ.
And hi, everyone. I'm Mark Stovall. I'm a Deputy Program Director here at the Justice Center and looking forward to today's session. Thanks for joining us.
Thank you both. To catch everyone up briefly with the first session, Kevin walked us through how counties can define a problem, develop a shared understanding of that problem, and then plan for process improvement. So competency restoration came up as a key challenge in our conversation with several sites during that first session. So we already planned to cover some of that during this session. So we're glad that we can provide a space for Kevin to dive a little bit deeper today into problem solving on incompetency to stand trial. Just a few housekeeping notes before I turn things back over to Kevin. We did record the first session, and that recording has been uploaded on our web event page. Mark is going to send a link to that page momentarily in the chat. So we are also recording this session, and this recording will be available in about a week from today. So this entire session is ask and answer. So we really want this to be conversational. So please feel free to ask any questions either by raising your hand on Zoom, enter your question in the chat, or you can come off mute, turn your video on, and ask Kevin directly. So that is everything on my end. I will pass things over to Kevin to get started.
Great, thanks, PJ. So I think as we're kind of saying, like part of this is kind of part two of kind of like some tools and kind of ideas we talked about early this month. And so I'm not going to go through the presentation kind of from a couple of weeks ago, but a lot of those materials and ideas are kind of the starting point for even looking at really kind of issue like competency to stand trial. So in this agenda, I'm going to kind of walk through, really make sure we define competency to stand trial in a really clear way, because one, as a multi-state, multi-county effort, a lot of you are going to have really different interpretations of what these are, what the issues are, and also how your state deals with this at a county and state level. And so this is meant to be a little bit general, which is a little uncomfortable for me because usually I like being really specific. But I'm hoping this will kind of bring out some of just the questions you all have. And again, it doesn't assume you're an expert in the incompetency process. Doesn't assume you're an expert in any one piece of this kind of presentation. But I would say if you're a stepping up county, you're working on it, you touch all these different parts of the incompetency system. Because what makes it, I think, so interesting, and I'll have a slide about this, is it really does touch everything that stepping up does, but in a microcosm in a much deeper way, because these people tend to spend more time in jail, more time awaiting restoration, more time in hospitalization, and oftentimes have outcomes that aren't what we'd want to see. And so I really think the competency process, not in itself, but also what it represents, is really ripe for innovation and really kind of taking a deeper dive into kind of what's kind of that precursor and what can we all do collectively. And so the tools I'm going to kind of talk through today are really meant to give you kind of a toolkit to do this. I don't have answers. I think that's a part of this too, is that there's a lot of ways to address these things, and because it's such a big group, there aren't going to be one kind of set of ideas or answers. But I'm hoping this kind of framework gives you the tools to use it locally. Because again, part of this will be the PowerPoint. I'll walk through just some background information, but then hopefully during the Q&A we can actually start talking about what are the kind of questions you all have and how can we employ some of these tools. And then also, I think as like a receipt after the meeting today, you actually will get kind of like the whole toolkit as well, just to go and take and use yourself. So the whole idea is we're going to give you kind of a framework to kind of think about it, get some conversation about what really drives incompetency in your jurisdictions and the questions you have. And then how do we kind of use a toolkit really to start getting really more specific and not just maybe too focused on one part of the court process, but bigger picture, where do these people fit into kind of the work you're all trying to do with stepping up counties. So I'm going to share my screen, and then I think as PJ said, please do stop and ask questions, and then kind of like we can either raise hands or we can maybe raise hands at this point. But the idea is really to make this kind of ask and answer as we go. And again, my expertise, a lot of it's in California with certain counties, and that gives me a very small window into this bigger national challenge. So I'm gonna make sure you are all kind of to be able to bring this out of what you're seeing, what you're hearing, what you'd like to know more about, and also share amongst each other. So I'll share my screen here. So as I mentioned on the agenda, the idea was today to really build on some of the system level planning components from the October 3rd presentation, which are I think linked in the chat. But really that kind of goes through, you have to start with some guiding notions of what you want your group to be and what you want your stepping up kind of priorities to be, as well as do some basic system mapping, some kind of collaborative work to make sure you kind of understand each other's priorities, and really have some basic kind of reference points to make sure you're all at kind of at a system level ready to start planning for some of these efforts. So I'll do a brief overview of that on a couple slides down. So I want to make sure we're building on those components. Also learning how to collaboratively develop what's called a root cause concept. And what I like about root cause, it's really good at kind of looking at a complex problem that isn't just one thing of just like, let's just do this differently, but actually it touches lots of different things as a precursor, but also in the process itself. And so really the fancy way of saying root cause analysis, root cause concept is really getting away from kind of letting the solution drive your analysis or drive your solutions, or your solutions driving your discussion, but actually kind of saying, well, what really is driving this from a lot of different perspectives? And I'll show a version of this. And I think, again, it can be adapted to your own local interests, but really it's great as a stakeholder tool, but also the people that are actually in this process to make sure you understand it. And then develop a problem and a goal statement specific to the incompetency process, because you'll probably see a lot of things that seem intractable, but if we start small and be specific and actually have goals, we can actually start to kind of address these things, but make sure we know where in the process is actually addressing competency. And last, use a planning matrix that I use is helpful just to prioritize, because a lot of times you come up with so many different priorities. Where do you start? What is the thing that will have the most value, have the most impact on your goals? And I'll kind of mention those in a second. But also make sure you can then follow those through. Like, how do you have the plan and then enact it, and then make sure you kind of know where you're going with it? So I have a kind of an approach we've taken that actually helps to kind of show that, and also make sure you're collaboratively planning as best as possible. Because a lot of the stepping up work doesn't assume you're all on the same team, or let's say have the same boss, let's say. So sometimes you have to work collaboratively to make sure you're all doing the things that really do work for the collaborative. And again, that's a really big challenge, but with tools like these, it helps to really make sure we're all on the same page across agencies and across players, and then have a way to present that. So I'm going to jump into kind of take one little small step back. So I don't want to assume everybody has the background knowledge of what the competency process is or what it really represents. But there's two I would say national standards that really do define what incompetency is. But I think at its base, it's when a defendant can't actually participate in their own defense or really able to understand what's happening to them. So an example might be somebody who has maybe a severe mental illness, let's say it's schizophrenia, and is really decompensated, really does, like their lawyer really doesn't know if they're understanding what's being offered to them in, say, a plea deal, maybe an offer of probation, maybe an offer of, you name it. They really can't understand what's happening to them, nor can they really assist the attorney to know what's the best way to defend them. And so that standard is called the Dusky standard. And really what that does is kind of form the basis for all states and how they look at, and that's probably maybe a big statement, of how most states will actually, if not all, will actually have a base of what incompetency to stand trial is. So that's kind of the basis, and it's been around for quite a while. If you look at your own state standards, they'll actually have references to what those criteria might look like. And it helps to kind of know this person's in a situation because they're standing trial, and really their defense attorney can't assist them. That then becomes a challenge, because how can that person really get a fair trial or a fair access to justice when they really can't understand what's happening to them? Because the alternative would be they keep going through the court process, they have a disposition, and they don't really understand what's happened to them. Maybe they've taken a plea they don't understand, or they're so severely mentally ill, this person will really kind of never get it. It's really not an unfair process. So that's kind of a main part of that definition. The second part is then when they're found incompetent to stand trial, how long does that actually restoration take, and how long do they have to actually make them able to stand trial again? So restoration has a lot of definitions. And so I think the definition I usually use is, are they able to understand what's happening in the court process and really identify the pieces of the court process that's happening, and then also participate in their own defense. So that's a very simple definition, but usually that comes with treatment, medication, and usually quite a bit of time to actually get them back to they can really understand the process. And the challenge there is because you're trying to just get threshold is really for them to be able to stand trial. That's not the same as them. They're not well necessarily. They're not connected to services in their community. They're not necessarily on a different track. They're just able to now continue with their trial. You would hope that that would lead to, again, medication adherence, treatment, all those things we kind of want for somebody to be, on a better track. But all this really does is get them back to be able to stand trial. How that program works locally is really where you get the value for it. If it can then be a jumping off point to other services, treatment connections. But mainly it gets them back to ready to be able to stand trial. So this process obviously will be different for what those time standards are across states. So definitely look at your own local standards. They're also usually different for misdemeanors and felonies. In California, they've actually reduced the ability to actually go to our kind of state hospital for misdemeanors. So they've really reduced that, but you can still go for a felony. But so your laws will differ in your community. But when you kind of think about it, without understanding kind of what that next step is after for the restoration, it's hard to then know what you would do with the people in front of you. And the last part is that competency is really it's a social standard, because at the end of the day, you can be have severe mental illness in the community, really challenged. Maybe you're really kind of off. You're not really in contact with anybody. You have a very high level of mental health need, but if nobody's really coming in contact with you, that's really a different story. But suddenly, if you come in contact with the justice system or with police or with the court system or the criminal legal system, then suddenly you can't participate in that. So that's kind of a different story. But once you come in contact with the court system, you really have to be able to understand what's happening to you. And so I kind of want to stop there and just see if that that definition kind of resonates with people's kind of working definitions, or if they have other questions about kind of what this looks like, or even how to go find their own their state's definition of this. Okay, moving on. So one document that I've used that I think is really helpful in this, and I'm gonna zoom way in. PJ, is this big enough to see, or is it still a little teeny? I'll make sure I'm zooming in.
So we can maybe get a tiny bit bigger.
Okay. So this also will be attached as kind of like as a Visio and as a PDF, so you can download it and adapt it to your local needs. But this is kind of the overview of the competency process. I really like process mappings. I think I'm a very visual person. So what I try and do is both like take statutes that I kind of read or policies and say, well, who's really doing the work here? What are we saying about how long it should take? What are we kind of seeing as kind of the off ramps and pieces of this? Because without a basis for it, how can you really innovate or really understand a process without really getting to those pieces? And so this is kind of done from I would say from a county perspective. So I'll give the brief overview of this and then go into a little more detail as we have questions. But so really it starts with them, say they're booked into jail. They may or may not, you don't have to, you can be incompetent in the community as well, but it's just less common. So I'm going to use the example here of maybe a felony where they're most likely to be in custody, not in the community. And really if they're booked in, the court will arraign them after the DA has decided to file the case. Maybe they're arraigned, maybe some pretrial hearings. But on a concurrent basis, the defense attorney usually is the one who is then looking at whether or not that person can actually help them with the case and really meet that standard for the ability to kind of assist with their own defense. So really what triggers this, and I would be curious if people have different experiences in other states or other communities, is that really it's the defense who's really usually the main kind of driver of those motions to file for what's called a doubt incompetency. And really what that's saying is the defense feels they can't participate. I think the court in some jurisdictions can also generate these as well, but really it's the defense saying, this person is not able to help me in my defense. I'm filing a motion for a doubt incompetency. At that point, the court would then suspend the criminal case. And then usually an assessment is being done to make sure that the person actually does meet that criteria, really looking for mental health needs and really specific issues that'll basically kind of ensure that they are actually unable to participate in their own defense, and what that mental health need is, and would they even be restorable if sent for restoration. That assessment is usually sent to court. And then you can also have a trial over their competency between the DA and the public defender if they disagree about the pieces to it. But at the end of the day, if the person returns incompetent, they are found. That document then says they are now found incompetent. If they're not, the case just resumes again. But if they are, usually a commitment order is then issued, and then some kind of placement assessment is made, whether or not they need to go to let's say a state hospital or some other kind of placement to be restored to competency. Usually they'll be placed on some kind of a wait list, which is, can be a short amount of time, could be a long amount of time, but usually it's some kind of a waiting period to then be placed for transport. Then you have the jail, usually the jail or the sending agency, then moving the person out to the other facility. The competency restoration process begins in the hospital, and then usually over some kind of like routine quarterly hearing, or at least in some states it's quarterly, some kind of routine hearings, and you make sure that the person is making progress on that, and the local court is hearing those concerns or those questions. If they're restored to competency, then some kind of certificate of competency is issued. So some kind of verification that, yes, this person is back, given the medical standard, the mental health standard that the state has. They're then maybe returned to custody in the local jail and their case resumed back in court. If they're not restored to competency, they might be referred to some other kind of placement, or at least to maybe some kind of conservatorship if they're not able to participate in their defense. So the reason this is kind of useful, or at least I find these kind of maps useful, is you kind of know who controls what part of the process. Like who's making the decision, what generates that decision. Because if you're only looking at the part where someone's found incompetent, you miss the 6 or 7 other steps that other people are taking. So when I'm kind of looking at how to kind of unpack a process a little bit, we want to make sure we understand almost as much as we can to know what led up to that event. And if you're looking at a map like this, the other question you probably want to ask is, the person's booked into jail, but what happened before that? What are the circumstances around that person's individual journey into this? Possibly the public safety risks, other things as well, previous cases, but that's where kind of more of a data analysis can help to fill that in. And so what I'm hoping from this, that when we're kind of looking at this, is actually it can be helpful in actually looking at, one, what would you do differently? And then 2, where are the parts of this you can really unpack and really figure out what that root cause is. So I want to stop there and see if this is kind of a useful diagram, or if any people have questions about kind of how this works, or this is a similar process to what they see in other states. And this will come back when we start doing some of the project work. So let me zoom out a little bit. There's I think really, if you're kind of looking for a little more background and kind of some of these kind of different realities across states, a study from about 10 years ago, 2011, about maybe 14 years ago, actually did a really good job of combining a lot of different studies in what's called a meta-analysis. And the value of meta-analysis, it's like a study of studies, is that sometimes if you read one study from one group, you get that one study, but sometimes if you actually can combine things, you get much better perspective, at least on what some general themes are. And because we have 50 states with sometimes 50 variations, probably not so different, this study actually looked at kind of some of those standards. And obviously the first question would be if the standards are the same for who can even, a doubt of competency can even be raised. But what they found, about 30% were found incompetent, which means that of the people where there was some doubt of competency, 30% were actually assessed to be incompetent to stand trial. So again, how many people were actually have a motion to file will kind of determine how low or high this number is, but gives you a basis for kind of what this study found across a number of different studies. 80% of people then who actually met, I think across studies and across different diagnostic criteria, are also restored. So, there's also a pretty good track record for restoration. At least this study found like 80%. And usually that happened within 90 to 120 days. The value of this is also you kind of get out of looking at your own state and saying, what do other states seeing in terms of their systems, and what can we expect locally when we actually have somebody referred for that. A couple of things I found kind of useful on the predictive side were, well, what are the kind of like things that put people at higher risk of IST or being found IST? Psychotic diagnoses were a big driver of what puts someone at risk. Also being unmarried or unemployed. These last two, or at least the one in the middle, I think it's less about being married, but more about social connection. Because I think one of the themes you find with a lot of people that are found incompetent to stand trial, they lack a lot of those social connections you might need to really stay connected to the community, to society, and kind of pro-social means. And so I think what's interesting about this, that you're kind of looking for people at risk, how do you find people that are somewhat socially isolated, or that don't have a lot of things that draw them back into the kind of community? And I think the part of this that I think are also useful is like less predictive of being incompetent are the crimes themselves. Usually the crimes of violence aren't necessarily predictive. Race, they really didn't see a lot of differences, or education level, or even gender. So again, the things that are kind of helpful in saying, well, what puts someone at risk of IST, it might be things that are more subtle than what you might see on a booking sheet or what you might see on a court docket. And that's where it kind of takes more of that stepping up mentality of what more could we do for people rather than just look at kind of the basics of why they're there in front of us. The footnote down here is it's an open document. There might be more recent ones. I haven't seen ones as kind of robust as this, but I do think it's kind of worth a look as kind of things that I think where the field has gone recently to think about really what drives this kind of level of engagement. All right. So now kind of to the meat of this. So why is incompetency a useful area for stepping up efforts? And again, almost all my work is at the county level. So I've always kind of looked at this to say, how can counties design programs, solutions, ideas, priorities with what they want to do? And I found that because people that are found incompetent often have multiple previous interactions with the justice system, really there's an opportunity to say what came before that, not just look at why the person's in front of us now. And because there are those overlapping needs, like behavioral health needs, criminogenic needs, and housing needs, it really does make it for a really good way to kind of look at some of those stepping up tools more generally to then dig a little deeper. And I think the other part is that this takes a lot of coordination and really kind of knowledge about each other to really kind of figure out where you can kind of see and improve these systems overall, and not just look at the competency process itself. Because I think what makes stepping up kind of a powerful kind of tool for this is you're kind of looking at the system level first, and then you're kind of jumping into some specifics. So the part of this I don't want people to walk away with is we're not trying to like make the incompetency process extremely, let's say, efficient by itself, but more to say where does that fit in a system of care? Because we're not always looking to have more people found incompetent or maybe less people found incompetent. We're looking to make sure that the right people are found incompetent to restore them to competency to stand trial. And I think the part that sometimes gets confusing is if we're looking to reduce the number of people found incompetent, we don't just want to have the courts or the public defenders say we're just going to find fewer people incompetent. We want to say, well, did they get to useful treatment? Were they diverted to something that actually was of use to them? Did we work ahead of the time to actually make a real contribution to this, not just have fewer people meet this legal criteria, which is different than them actually being connected to services or connected to what will hopefully make both the community safer as well as them more connected to the treatment. And last bullet there, individuals at risk of incompetency often don't fit like in some way, like they're either the criteria they have for treatment, they don't fit. Maybe their own kind of interest or engagement doesn't fit with what's available, and really kind of does require more collaboration. And this goes by a couple different names, but really to make sure that the people that are found incompetent, you do kind of have a way to kind of look at what else could you have done? What more could we have done? Knowing that these people are already some of the more challenged and some of the more at risk in our community of a lot of different negative outcomes, and not just maybe a public safety risk. Chance here. Oh, a good comment there on the study I mentioned. They've already been found incompetent once, so actually they were kind of they were already, I guess maybe the sample size in terms of they were already inpatient. They weren't necessarily people in the community. So the difference here is that a lot of those would be people that are already in that setting is one part. That's to make sure we kind of back out and say everybody in the community though might be a different sample or wider. All right, so how do we get to this and make some tools out of it? So one of the prioritization efforts could be one, we started this a little bit before, and I'll do this kind of quickly and then we can kind of like maybe do more of a discussion and kind of open up for kind of how to use some of these tools. Really, how do we prioritize some of these projects? Because in our first kind of step on October 3rd, we need to have some kind of collaborative direction overall. And that really helps to make sure we're all kind of aiming for some of the same goals as a stepping up collaborative. The second one that can be useful is also making sure we have a good sense of what each agency actually does. Not just what we think it does or what we kind of see the agency's name as, but what are the revenue streams? What are their cost drivers? What are the different services they offer? What are the different things that are maybe grant funded? And these are called a canvas map because for lack of a better way of describing it, it really helps to kind of see all the things maybe an agency has that it does versus what you might think it does. So it's really a great collaborative tool and a very simple thing to kind of start with to make sure we all kind of understand each other a little better. And then step 3 is using things like the sequential intercept model or other process maps to identify service gaps and other kind of issues. And really this can come out because you may have a very robust set of programs, connections, and services, but if you don't have the things really kind of connected together, you can always kind of do more, you can always innovate. But the idea is to kind of have one place to kind of look at all that in one place. And these process maps, and I found sequential intercept model and just that whole idea very useful, as well as what comes out of it to make sure there are enough I would just say off-ramps, you might call it, or ways to make sure people can be connected to services throughout the justice system, from crisis response on out to reentry throughout the whole system. So today we're going to focus a little more on kind of these pieces that are specific to the competency process. And I guess the leap of faith, I guess, or leap of kind of the leap I'm asking you guys all to do is, let's say you've done the work on the front end. You've already kind of put together, you have a good collaborative direction. You already have kind of the collaborative kind of agency mapping done. You have the sequential intercept model. You're kind of ready to go deeper. So ideally, you'd have these tools kind of for everybody to kind of sit down and make sure they understand things together. Because now we're going to get very specific. And I would say this is a much smaller portion of your total population that you're looking at from a stepping up perspective, but it's very specific and it has very specific legal pieces to it. And so the steps I'm going to kind of walk through the day, and I'll do kind of maybe 5 or 6 slides just to kind of give you some orientation to it. And I'll stop under each one to kind of just have people ask questions. And then we'll go to like a little spreadsheet version, actually, then we can kind of do them in real time. Really kind of what does that root cause concept look like, and what are we trying to get at? Why can it be useful for this? What I call is a 5 why concept. And this is kind of, and it goes by lots of names, but really the idea is to not just say, we need more of X, but why do we need more of X? And the 5 why idea is you actually go through it 5 times. You kind of go through 5 iterations of that to go deeper and deeper, to make sure you finally end up with a pretty good, well thought through basis for why you think this is the issue it is. And all these all work together. So they kind of come from, you have a good sense of the root cause, then you have a good sense of why it's happening. Then you kind of move to then create an actual problem and a goal statement. Because the problem and a goal statement then says, what exactly are we doing, for who, when, and how? And it really does help to make sure that any kind of program design is done with that in mind. Step 7 would then be actually doing some data analysis. Make sure that you do kind of understand, like check some of those assumptions, check how these things work, and I'll provide kind of a template for how people can either, if you have access to a lot of automated data, great. Or if you just want to do a case file review on a couple of people, the same tool would work. But because it comes from so many agencies, it becomes harder because that's not all information any one agency would have. And obviously some of it might include medical information, so it becomes much harder to share information. But without that kind of look across multiple agencies, you won't be able to access it. Last, a tool for prioritizing projects. So once we kind of get our great ideas, what are the kind of steps we would take to actually prioritize? And then last step there is then how do you kind of implement and a tool for implementing some of those things? Because with all these things, if they're multi-agency, the biggest risk is going to be changes in staff, changes in direction, changes in motivation, changes in funding. So how do you kind of at least have one document that keeps everybody kind of going the same direction, and also make sure you can kind of see the successes you're having? And I think the plan, do, check, act methodology is, pretty well known. Didn't invent it myself, but I found it when you're kind of trying to package it together as to why we're doing this and then how we're going to do it. It's a really easy way to have one sheet of paper and not a 30-page document that people, probably will. But it's a pretty visual kind of active learning, active collaboration tool. So with that, I'm going to stop there. Any questions about kind of like anybody use some of these tools before we jump into kind of some examples, or anybody have any kind of things they've seen that have worked in kind of their approaches? I'll jump into some examples. So one of the tools, and I think this is this one I kind of use for incompetency in a California county. And I think the reason I've kind of gone more and more to these tools is that I think they really do help to show how complex some of these issues are. And so the idea behind this tool, the root cause analysis kind of tool, is that we really kind of make sure we have all the different kind of in a visual format. How do we make sure we're kind of like getting everything that is kind of that cause and effect of, because these things aren't working the way we want them to, or maybe because we see them as gaps, what is that then affecting? Because the effect we're having is that people are unable to participate in their own defense and being found incompetent to stand trial. So in some ways, you kind of start backwards. You kind of start at the end and work backwards a little bit. But what this allows you to do, and this is also called a fishbone drawing, is that what it helps you do is then kind of see what these different parts are that actually are contributing to it. And the idea is you kind of go through, it's kind of a brainstorming exercise with stakeholders to say, we know that unmet physical and behavioral health needs are a big part of what people might be found incompetent because they have untreated needs. That is part of their diagnosis, their assessment. How do we kind of put that community-based part in that, because that all happened before maybe they were found incompetent. because of maybe the lack of placement, like, the examples here are lack of placement and capacity to serve clients with SUD and mental health needs. The client doesn't engage in services when they're offered. Maybe the county behavioral health department lacks the capacity to really engage clients because that's not part of their funding mandate. What these tools can kind of do is say, okay, we can kind of at least isolate what some of these issues are in very specific detail, but then we can kind of go forward and start asking why. So this is the connection. You wouldn't necessarily do all these, but a way to kind of acknowledge that this is a complicated topic gives you that. And so these other examples might be from the housing side, obviously inadequate housing, lack of case management, substance use needs, and some of those limits could be also parts of that. Then the last part there is actual justice system contact, be it crisis response, law enforcement policies, or even kind of uneven capacity for around collaborative courts. Could all be parts of this that lead up to someone being unable to participate in their own defense before they're ever actually in that situation. So think of the ones in the top as more of a community factors or system factors. The ones in the bottom, we'll kind of talk about that, are actually more specific to the competency process itself. So for a doubt in competency, since that trigger is really going to be someone not able to participate, really the attorneys have to, usually the attorney has to weigh the ability to participate as it changes in a case. It's not always yes or no. Just because they're arraigned and they seem okay doesn't mean they're okay the next day. It doesn't mean they're not okay the next day. It's really changing. Something's changing over time. So how do we figure out what those how different attorneys interpret this law and actually in turn interpret the motion of incompetency? There's also a lack of off ramp sometimes once the doubt incompetency is made. It has to go through quite a few steps to actually end it. So again, you kind of had this process where once you've kind of filed that motion, you're in that process. Excuse me. And also clients are oftentimes decompensating in custody and also refusing medication possibly, which then furthers kind of that decline, but you don't always see that. So really we're trying to figure out what's kind of happening before they even get to be incompetent. Really it's that doubt and what are the kind of things around that part of it to unpack that kind of set of decisions. The middle bone here is in the evaluation of competency. What are the kind of things or kind of issues we're seeing there that also might contribute to that? So one could be wait times to actually see an alienist. If you don't have enough capacity in your system to really have these timely evaluations, could that also further disrupt or further someone's decompensation while you're waiting for something? Medication adherence sometimes. Also, is the person actually taking medication as ordered or as needed while they're in custody or in general? And then also, sometimes people become incompetent after or become competent after they're actually evaluated. And then that also then creates a barrier because once they've been found incompetent, how do you kind of get them back to competent if kind of the train has already left the station around them? That kind of need to then move it through the court system. How do you kind of find off ramps for somebody, even if they come back to competency right after they've been evaluated for some reason? Then last there is then how do you kind of look at different ways of engaging them in treatment or even post restoration? EASE is a medication program that our state has put into place, and really it's meant to kind of be an early intervention or early medication program to get people kind of starting to engage on medication right after they've been found incompetent. It's been found very effective, but you have to be found incompetent to start that program or use that funding. So you kind of you can't really prevent it because it's part of what's already happened. So is there a way to use that same medication engagement process? Sometimes returns from the state hospital, you need coordination of care. Something that's really challenging to do when someone's sent back and right away their case is moving again and they might be dismissed or it might be released from custody. Again, that care coordination can be really challenging when they're coming back. And then last, lack of capacity for placements in the community once they are restored to competency. And so I think the idea here is that then you would choose a few. So if you're kind of going through this process with some rigor, you would kind of have a group that would actually meet, talk through these, really brainstorm these of kind of why it's happening in your community. You're not really prioritizing it, you're just listing them. And then kind of choose the ones you really think are going to be the ones that you want to kind of then focus on. So I want to stop there and see if the visual kind of makes sense. And then if these kind of elements, resonate even with, across multiple counties of ways to kind of approach this. I'll stop for a second.
And everyone, we're a smaller group today, so please feel free to unmute yourself with questions you don't have to put in the chat.
We'll come back to the like also in an example. But in the spreadsheet, I think the link that the PJ sent, that also has a version that you can actually click into and edit for yourself. So I think the stakeholder part of this would be really, you can start with a blank one. I like kind of the theater sometimes of kind of like the planning process to make sure people know that we're not preloading all this. But the idea could be, start with a blank one, but just even the headings themselves could be useful in how you think about what you're interested in locally, and then what's kind of working from whose perspective. So I think for this, it's like, and I think maybe that the important part here, there isn't one answer to any of this too, and there's not one set of priorities. So the example would be, you're kind of starting with this big complex problem. And I would say you can probably fill it. You can use the same tool for anything. I think not anything. I think in our meeting last time, a couple weeks ago, we actually used it for housing. So again, there's an example up there of housing. But I think what it lets people do is kind of see that, like, what are we really clear about the problem we're trying to solve? And are we really clear on really what precedes it, what influences it, and then what comes after it. So again, you can kind of take this out, pull all these kind of names out of it, or if they're useful for your local conversation, see what happens. But ideally, you would then say, what are the ones we really want to prioritize, and what are the ones we want to kind of dig a little deeper on? So I'm going to use kind of an example here for two of them in this next slide, and really then do what's called the 5 why activity. And I would say this is usually meant to be something that could be brainstormed, or it could be one person doing it themselves, depending on your role. But so let's say we want to choose the one that's clients are decompensating while they're in custody. And so what that means is they are, one, maybe they're not adhering to their medication. Maybe their situation is really getting worse while they're in custody, awaiting either their court case or various parts of it. And that's really the one that we think is the biggest issue. So what you would do is fill out on the spreadsheet. Probably, if you have opened the spreadsheet up, you can kind of see it there too. Really, you click into that and really kind of you choose your top contributing cause. I think you really think is the issue that is kind of why this issue is happening. And then basically you go through and start writing out the why part. So it seems a little, elementary. Actually, what helps you do is really make sure that you can articulate why it's happening and not just start at a really high level. So obviously, why is it that clients are decompensating in custody? They don't take their medication. Why don't they? Why is it that they aren't consistently taking their medication? There really isn't a way to engage them in custody. Maybe for staffing reasons, maybe for security reasons, it could be for movement reasons. The whole point is you kind of start to document kind of, well, why isn't it happening? The third one there is, and why isn't there a way to engage them in custody? There isn't any staff or policy to medicate. Let's say there really isn't an organized way to engage people or help them with medication. Again, that's a gap. So then you kind of get to this last one or two, you're kind of getting down to kind of what you want to do about it. So why is it there isn't any staff or policy to help with medication? These are done in an ad hoc way. Yikes. Let's say the issue was that people actually isn't happening because really it's just done as needed and it's not really an organized system of delivery. So instead of it being somebody who's really like, this will be the process to engage someone in custody on around medication, there is no way to do that, and it's done in an ad hoc way. And then part of the reason that's being done that way is because there's no real policy to address it. I'm not sure what happened there. There's never been funding or a policy to address it. So part of this could be, let's still start to go and develop a policy to actually go do that. And so you kind of go from this very somewhat abstract idea to let's go kind of make sure we understand what all these are and really kind of why it's not happening in the first place. And because I think a lot of times, counties work under the, whatever is being done today is probably not that different than what was done 5-10 years ago in certain areas. It also allows you to kind of then just go ask why to other people that have either been there longer, have better knowledge of this topic, whatever it is. And I think if there's an approach to take with this, it's not just to be inquisitive. It's also just to be kind of humbly ask, like, why is something happening the way it's happening? And again, based on usually stepping up groups can have a lot of trust built into them. It's a way to kind of make sure you can have a structure for asking those inquisitive questions and really get to beyond just kind of the obvious answer. And then this next one is kind of the same or a little bit different. And then probably one that I think is, a challenge that I think also comes out of this. And this is one where if we don't really have any opportunities for diversion, what do we do? So system partners don't have options for diversion or treatment. So why is it? There hasn't been consistent staffing or coverage. Why isn't there staffing or coverage? There hasn't been a funding stream. Why hasn't there been a funding stream? There hasn't been a place or a resource to take them to. And why hasn't there been a resource or place to take them to? The funding and the partnerships were too complex. Why are they so complex? There was never a consistent effort to build a system where because there weren't funds. So it's a little bit kind of circular sometimes, but the idea is to kind of come back to really why isn't there a diversion program in this case? And it's because really we never put the focus energy into it. And I would probably say with a lot of diversion programs, like what's the criteria? And then what's the actual diversion resource to take them to? So with the 5 whys, I think it's an easy way that anybody can kind of take kind of a complex question and kind of break it down the best they can, and then kind of make sure that people kind of see it the same way. So I would say it's more of like a logical exploration exercise. And when you're kind of looking at it, it also then lets you ask questions of other people. So what does this come out as? A problem and a goal statement. So the whole idea from this too is that we want to kind of look at some of these complex problems and make sure we understand them. And so the problem we're trying to solve is people with mental health needs are being found incompetent due to a lack of options in the community and are complicated by I had an idea there, by care coordination issues. And so what do we want to do about it? Within 12 months, we want 75% of the people hospitalized for restoration, and then we'll see coordinated care at the point of release or case dismissal. So we want to build a program that starts to really get at that issue. And the reason we want to do that is then be able to kind of see, well, why isn't it happening? And be able to kind of then get down to very specific reasons that we think it's not happening. So we build our program around it. Some of these, again, you probably could put in a lot of different kind of stepping up collectives and programs. But the idea is to kind of make sure we're really clear about it and why we think these are part of our, part of the reason why we think our goal matters, as well as our problem statement is really the right one to solve. And I'm not going to read through all of these, but a way to kind of group concerns and then also start to group solutions as they go. All right. And then a little bit about data. My background's actually, a lot of it is kind of how do I apply data to kind of bigger policy issues. And so I'll do a quick slide on this and then we'll kind of stop for a sec. And that really, like, data analysis helps to kind of bust myths on a lot of things, but also expand your knowledge of what these people actually mean. Data is not the truth. Data is kind of a version of the truth, because really just because you can have some, like a data set that tells you something doesn't mean there's not stuff missing from it. And I think in my experience, incompetency is one of those really great examples of that, is because if you only see the court story, you're missing all the other stories on top of that. And because it's such a, people found incompetent don't always touch every single part of the system in the same way, you end up with different narratives. And so in my experience, there's probably 5 areas of data you want to kind of gather about people. One, their service needs and history with services. So that could be more on the behavioral health or the health side. What is it they need? Their demographics, past court and justice experience. So, how many cases have they had against them? Do they have a lot of misdemeanor incompetency leading to felonies? How do you kind of get some background about what that part of their life is? Medication and clinical engagement. So what are their kind of medication needs on top of other things they might need? And then really kind of past IST or even current specific case processing. As I kind of mentioned in the flow chart, what kicks this off is a doubt of competency in most jurisdictions. Somebody has to doubt this person's ability to go through the court process. That leads to an assessment. That leads to a finding of incompetency. Even kind of looking at those as hearings and kind of why does it take the amount of time it does is really specific to that IST piece. So the more you can kind of look at things, both like the first 4 are probably more general. This one is more specific. It gets you kind of thinking about what is really going to drive some of these conversations about what isn't working and what we want to do more of. And in my experience, a little small, is there's kind of like a couple different times that people that end up kind of with being found IST. And I think usually we kind of jump right to that high utilizer, is that the person who's basically having multiple interactions with the justice system over and over again seems to be in some kind of a persistent crisis, and really there's nothing that quite works for them. That's usually the person that people think the most about. It goes by lots of names, high utilizers, frequent flyers, familiar faces. I think we're always trying to kind of figure out what's best for people that really we're just going to have a hard time finding how to connect them to something that's more stable. And also there's a possibility they also pose significant public safety risks. But the idea is there's certain people out there that are just cycling through. Why? So again, those might be solutions that are more of like what other kind of services can we offer, or court partnerships, or more wraparound style care. But we also see is the other two there, which are a little bit different. And what I've kind of had the experience with is that a lot of times there'll be a single booking on a very serious crime for somebody found incompetent. And the first question I kind of ask usually is, well, what happened before that? Because if they've never really been in the local jail system before, you can probably say, were they in a neighboring system? Were they somewhere else in the state? You can go that direction. But a lot of times it's just something that comes out of nowhere is kind of surprising to people. And I think having kind of a better knowledge of what happened in the community before this person was found incompetent with a more serious crime is one kind of aspect of this that you wouldn't get through doing normal kind of analysis, because you can start looking for smaller, more unique cases that are a little bit different than that high utilizer, familiar faces kind of narrative. And then the other one is kind of more around people that seem to be kind of ramping into some kind of a crisis personally. And then they also start to get more and more of the justice system resources, almost like, not out of nowhere, but maybe over a year or so. So they're kind of like ramping into different things, and that obviously you want to kind of avoid, but when you kind of finally find them IST, they've actually been through a lot of different steps in the process. Maybe it's quick, maybe it's crisis response, maybe it's other kind of short-term jail stays. What you kind of find is like three different kinds of people there, and they don't always kind of fit that one narrative of somebody who's either, somebody who's obviously committing a lot of serious crimes and is now found incompetent. They kind of find more there's a different type there. So I think a little bit of data analysis can help kind of at least understand who your population is, and also start to break it apart. So you're not just talking about them like it's one big program or system. And some random, like not random, but I guess like some things I think are, kind of useful when I've done this kind of locally is that about 40% of people discharged from a restoration. This is from a county, a California county. About 40% of those same people came back to the jail within about 15 months. So that's about a 40% recidivism rate. Recidivism defined as a return to local jail custody after they were discharged after being found restored to competency. So in theory, they were released. They went out. We don't really quite know what happened to these folks, but 40% at least are come back. And those folks in theory have received some kind of services and some kind of restoration. But really, what else could we have done to really connect them? And so it's things like this that tell me that it's not just about the person found incompetent. It's also about what we do once they're restored to competency and what the continuation of that court case looks like. So that's kind of one way to kind of use data to kind of see like where are these issues and why are they happening. And then last one, this is a little more wonky, but if we're going to talk about diversion and talk about things we want to do differently, we have to kind of talk about what that cost is and where those slots are going to come from. And so when we think about kind of avoiding kind of like either state hospital, kind of say state hospital beds for people to be restored, or even local jail beds, you've got to build programs that have an alternative. And so in a couple of counties, we kind of end up trying to build, like basically kind of estimate the impact of different policy choices. So let's say that you have, in this scenario, these different lines represent a population and a program. So let's say we want to build a diversion program. That's going to have a caseload associated with it that's outside of the jail and probably outside of the state hospital system, because we're building this diversion program. The challenge sometimes becomes it's very seductive to say, but we're going to divert all these people, but do we have sustainable funding for this diversion program? And oftentimes that's kind of the afterthought, is how do we build a sustainable program, not just one that's funded by grants? And so in this scenario, over a 3-year period, this program that say they have one referral a month, about half people actually accept it. In theory, that person would have had 24 months on diversion. That would then generate almost like about 9 people, sorry. That would avoid 9 jail beds, but create 8 diversion slots. And that kind of goes, one time at some point though, that kind of has the effect of saying you got to almost like build the similar amount of people outside as you do inside. And I think sometimes that kind of funding piece gets lost a little bit, is that to avoid that longer jail stay, you've also got to support somebody for a longer time as well. And so even though you're having this one referral a month, only half of them accept it, that person's probably going to be in some kind of a program for 2 years, if not more, to avoid that, 6 months to a year in jail. So you have to build both programs to make sure you're actually, again, making it sustainable. But what kind of the data analysis can tell you, though, is that how many people are actually coming through, and how many people actually would be even amenable or appropriate for a diversion. So instead of building a program first, you start with kind of what that demand would be and what some of those pathways would look like. And that's kind of on the data side. And I'll give you guys a template of kind of basically how you can kind of go collect this locally. And so last little tool here, this is kind of a prioritization tool, because oftentimes we kind of have, we have lots of ideas, lots of things we want to do. And this is like probably not, this is kind of more of a strategic planning tool. What it allows you to do is kind of like figure out one, say you have like this couple of strategies we figured out. We want to help people that are decompensating, maybe with some medication orders, maybe augment crisis response, support diversion, things like that. What this allows you to do is then kind of rank things and not just feel like you're choosing one, but make sure you can kind of know why you're choosing it. And so the kind of the three areas I think are really important, and this is in that spreadsheet. You can kind of play around with it. What it allows you to do is kind of say like, well, what kind of impact will these different things actually have on the program we're trying to set up? So let's say that we want to reduce the total number of felony defendants found IST. Okay, that's one part of it. So what would each one of these do to actually do that? Can we expand treatment options? What would each one of these things say to do that? So it's a way to kind of align your goals with actually some kind of a rubric and scoring matrix to actually have some kind of a collaborative view of that. So you could have it be one person, you could have it be a couple of people do it together. But the idea is to kind of weight these of how important you want them to be to then get at the impact. So if you've ever done a request for applications or an RFP, it's kind of the same idea. You're trying to rank things instead of just saying, let's just go with the thing that has the loudest voice. You can also have some just better criteria for what that is. And so impact, we usually people start with impact and really start and end there. Like, is this going to do the things you want it to do? But I think there's also other things to consider, and that might be the level of effort, how much capital resource or kind of funding it might take to build something like that, how long it will take. So again, that should be part of your conversation. Then the last two is kind of like project risk. How complex is it to really manage this project to completion? And then does it introduce some kind of litigation or kind of risk of other things that maybe are not part of the program per se, but kind of open you up to litigation that you may not anticipate? So how to kind of get a full version of some of these different programs, and then kind of plan accordingly. And so in this scenario, with this kind of weighting, you end up with kind of like your diversion program ends up being the one that you might want to go first, because it kind of had the highest rating across these. Doesn't mean you can't do the other ones, but at least it gives you some kind of a criteria to go off of. And these impact strategies are, are somewhat similar to what, a general stepping up framework might be as well. So you probably could use this for any kind of stepping up style program where you want to reduce people coming in, connecting to services, and also reduce returns to jail over time. And I think what makes this also useful is that intellectually, some things can't avoid something that's already happened. So, if one of our goals is to reduce the total number of people of felony defendants found IST, a diversion program really isn't going to reduce the total number of found IST because they've already been found IST. That's why they're there in the first place. But if you did something like crisis response or other kind of things, you might have more of an impact on it. So it allows you to kind of quickly prioritize programs and also have a very clear criteria for. And then last, and I'll kind of stop there for kind of open it up, and then I'll kind of show the spreadsheet version. But the Plan, Do, Check, Act is really just a project management tool, and I think it just combines all the things we just talked about, your problem statements, kind of clearly articulating what you're trying to do in terms of like solving a problem into one place. And what makes this kind of a common tool is it really kind of ensures all the project components are managed in a line. So it kind of compiles all the project planning, all the kind of documents you're kind of using in one place, and then also allows you to kind of show results and ensure there's kind of constant alignment and review of the kind of the key program aspects. Ideally, this can be used with maybe your stepping up kind of coordinating group or your leadership committee to say, if this is one of our really key programs, how do we show this to them once a quarter, once a month, whatever the timing is, so that everybody knows we're kind of on track and we're kind of moving in a direction we feel is the way to move. Because the benefit of the Plan, Do, Check, Act kind of framework is it also gives you a way to say, this is the program we started. Is this still what we want to do? Because things change. And I think the important part is to make sure that you're really always trying to work to align and not just kind of going forward without kind of a lot of input. But again, these can be very complex programs, so it's not the only tool you'd want to use, but it's, I think, a good way to summarize in one piece of paper, basically, digital paper, of how to do that. All right, so I'm going to stop there and just kind of open it up for questions. And I'll after this, I'll review the spreadsheet version that kind of goes through some of this, but I want to kind of stop for questions and kind of go from there.
There's been some positive feedback in the chat over many of these tools. So I just wanted to open up if anyone has any light bulbs that came up as Kevin was going through these some issues within the counties that could some of these tools could be useful. If you all could share any ideas that you had with us.
I do. I'm reading kind of Lauren's chat a little more too. I think that's I'm kind of, and I'm trying to read it as I'm thinking there's some kind of studying closely. Looks like you're kind of asking more about like, are the relative rates or who has a lot of ISTs versus not? And I think a comparison is really important. And can you say a little more what you're asking there? I want to make sure I'm answering the right, or if I can shed any insight, like what's wrong with my state. I don't think there's anything wrong with any states, but how do we know where we fit is probably your question.
Hey, I'm sorry, I'm not doing video. You all don't want to see what's going on over here. But I totally appreciate this talk. Sorry, were you talking about my comment on the Pirelli meta-analysis or which county?
Pirelli, that was the one. Actually, it was more like it's actually Yolo County, which is a county in California.
Okay. Yeah, I actually work with DSH too, so I'm nerding out on your data.
Okay.
Well, my comment on the Pirelli thing is just because if you're looking at, just the first round of evals, right, then more people are going to be found incompetent that first time around. But because most of it's the departments of mental health or state hospitals that are getting sued, so they are seeing higher rates like coming towards them. Or excuse me, they're seeing, if they compare it to the Pirelli meta-analysis, and sorry, this is also why you're not seeing me. I'm not feeling well today and I can't articulate myself very well. They're in their hospital, they're having like higher rates, or they have more people coming to them at the state level. But that 27.5 doesn't actually represent what's going on because Pirelli analyzed people that were already in the hospital. So it's only like 30% of the picture of what's really going on at the state level. Sorry, is that what you were asking me? I'm really making a great impression right now. Okay.
No. I can barely hold my voice on right now, so I'm feeling it. So I have to keep drinking my coffee to kind of like keep my voice.
Me too.
No problem. That was kind of part of it, because that's where the meta-analysis I think doesn't really it shows it really from a very specific point of view, which is that we're kind of already there. And the part when you actually, to me, like it was looking at all the people who were a doubt of competency rates really is what we're trying to find out from that group. And I think what I found, there's really not a lot of, because that's really kind of attorney or judge driven, like really you have so many interpretations of what that looks like sometimes. And I think that's why you might have wildly different rates of, and nobody really tracks 1368 motions or those doubt of competency motions, because it's some reason it's not tracked. But that would actually tell us quite a bit about how many people really are even entering the system at a similar place, whereas then they can't participate. Whether or not a doctor agrees with that, and that assessment is one part, but at the hospital part, people are coming at all different levels and basic engagement levels as well. And I just think that it's really hard in my mind to kind of create one narrative for what is a good state, a bad state, a good county, a bad county. It's so variable in what people are seeing from who's really contributing these people, like in terms of these motions.
Yeah, I mean, poor, excuse me, poor, like just various states like Washington kind of got that a couple years ago. And of course they have True Blood, but a couple years ago they got that, like, what's wrong with our state? Because they were seeing like 42% higher than that. And that's when I just started thinking about the Pirelli meta-analysis, is that it was like depressing the rates. So I think, I mean, so many people don't want to share their data because of the litigation and all kinds of things. So I think it makes some folks self-conscious with, why do we have this, or why is it taking us longer to restore people because of that. And I had, this may or may not be annoying, but I'm going to share a paper my colleagues and I just published on trying to do FOIAs for judiciaries across the country to just figure out how many evaluations are happening, because we don't have the data. We can't even begin to staff. And we wanted the data from the judiciary instead of the DMHs, because DMHs are often just accounting for the people that are IST. And only 17 states could provide quote unquote reliable data. and the Judicial Council from California couldn't because it doesn't have the centralized court system. So we still just like don't really know because it's so scattered and it's almost impossible to really figure out these rates unless Alabama and Georgia actually do have a centralized system for evals. But
And I think that exactly is kind of why, like in my work, like I think I've started more at the county level, because the county is really where all this is happening in its genesis. Like where, because the emotion is also hiding people that aren't able to participate, but they're able to hold it together, and maybe their attorney isn't as interested in their ability to participate. So in some ways, it's really hard to kind of get an apples to apples comparison, because a lot of times it's unseen. Because I think there's a thing that happens before that motion. The motion is the legal piece, but the person's not able to participate in their own defense. That doesn't need a motion. It'd be great if it did, but that can happen without anything happening, possibly. So you're back to really kind of seeing the only apples to apples really is maybe mental health rates, and then probably like lack of, almost like a very specific kind of jail mental health perspective, because that's where you kind of see everybody who's not doing so well, and that's not a clinical term. And how do you kind of see them versus who's actually being brought there? And thank you, Lauren, for that, because that's maybe I'll go to the data piece, because that's where I start usually with the court filings and the court hearings to know like what's that universe and what happened to that case, or what happened to that motion. But let me show that might help just your data collection too, because it does most likely start with the county of where the crime was committed or accused, and it kind of goes from there. But let me jump to that just because we're in it. This is kind of the spreadsheet, this is like the data fields, but this is, we'll basically have gone out and kind of tracked all this down for some number of people found incompetent or have that 1368. But really it's kind of seeing it through all the way from the jail booking to maybe what's happening around their actual court actions or hearing statuses, restoration, all these things that are happening before they even get to state hospital, possibly around their case. And then other things that might be specific to their actual restoration in gray here. And then also past, maybe for at least from California, like probation has a lot of this information of past specialty courts, probation caseloads, kind of showing past interventions or engagement with the criminal justice system, but more on an approach to kind of address criminogenic needs. And then obviously the behavioral health system, if they've had any contact with them as well. But in my experience, the behavioral health engagement usually is crisis response, quite narrow in what they're actually doing with the person, because that's the only engagement they've had, versus longer outpatient. So almost like it kind of completes some of these narratives around, one, who is kind of being found incompetent from a court perspective, but then also what other things are they touching at the same time to get them there? Because sometimes actually the reason they're booked in was actually more about like a lack of, how do I say this? They're not really complying with their previous court order. And then suddenly that they're being brought back in from a violation of supervision or a warrant of some kind. That is what kind of starts to generate this lack of ability to participate in their own defense. Then you're kind of in this little bit different situation. So it's not always new crimes, which I think was to me was interesting, because it's not always the first thing you're kind of seeing. But then the state hospital only gets a subset of those people, just as you said. But this, again, could be a framework. I'm not sure who would have this at the state level in a lot of places, but I think you do want to have at least like information about the, when the actual doubt of competency was raised, and then kind of what happened at their case, and then anything else about them in general. So again, this is probably way more than you're able to collect, in a routine data request, but I think it gives you the full context of what the system looks like for all these different things. So I'll kind of do a quick Excel spreadsheet walk. Oops, sorry. Oh, it's okay to self-promote. No, everyone's doing good work. I appreciate the link there. I'll take a look at it. So the idea here is that to give you all kind of basically not just the PowerPoint, but also a way to kind of walk through some of this in your own kind of jurisdiction. And the same thing, I think, also the slides and the PowerPoint and the spreadsheet that was kind of the backup to this was also available for the system level steps we just talked about. Or I'm sorry, the ones from early October. So really just kind of lays out in a little DIY kind of format, do your own root cause diagram. So you can take these, delete it, do whatever you want with it. You can edit these, have at it. And then really what it allows you to do is make sure you're adding back up to, the thing you're trying to affect. But all these are editable, so you can kind of use the same approach and the same tool template and pull it together. So that's that root cause diagram idea. Five whys, same thing. Same thing I showed, but this allows you to kind of edit in there. So if you think it's really about homeless, no capacity for housing. It changes it. So basically, it's a little tool that allows you just to basically do it on the fly and go through the same exercise. And you can change these, and it all just kind of updates for two of these. So easy to update, do it for your own kind of purposes. Problem statement, same thing. It's a tool to kind of write a really strong problem statement. And we talked about this kind of a few weeks ago as well on that call, more about designing a problem statement, but really want to make sure, kind of like a lot of those basic questions I think of when you're really trying to define what's happening, but what is it, who's it happening to, where is it happening, and when is it happening? And then why do we care about this from an indicator or an outcome perspective? And then be able to write the problem statement in a way that really does show, we have a really clear sense of what really drives that problem. So the root cause analysis and with the 5 whys really to make sure that whoever's trying to write this problem statement, either as a group or an individual, can come back with a really strong sense of why it's happening and not basically start with something that's either too distal, like too kind of disconnected from what's actually happening, but actually something that really does get at the issue and get at what we're going to try and do about it. Data fields are all the kind of fields I kind of gave a little bit of a start of this, but really kind of all basically kind of a laundry list of things you could go and try and collect across agencies. And so if you're working in a mid to smaller jurisdiction, you might be able to get 15 to 20. If you have 20 or 30 people, even a sample, actually go and kind of take a look at people across systems. Gives you a pretty good perspective on what this basically kind of what that history is, as well as that trajectory. So that's just the data field spreadsheet. It's just a spreadsheet, but the other way. So that's kind of the easy version. And then this is that ROI tool I mentioned, the return on investment. How to kind of then do this, that. So you can then change these fields into whatever you want. You can change these weightings. You can change these fields, change the title. All this is changeable. So it actually allows you to kind of do your own prioritization. So you don't have to, obviously don't stick with these. And really you're kind of trying to build from good sense of root cause, good sense of why we're doing it, and then a good problem statement. You then have a series of strategies to say, and then rate, and then come back with at least some way to rank them in terms of what you're trying to do. And that's kind of like, I think the big idea here is that we want to be able to kind of go from, we have an idea about a really complex topic being competency on out to something really actionable and feels like we're taking some steps. You can't do all this in 1 week, 1 year, 2 years, 5 years. But the idea, and I think this is why the stepping up connection is so, I think, useful here, is really it's about connecting ideas and things you've already done to then keep making progress forward and finding new areas and new things to kind of make sure you're doing that connection between mental health and the justice system as efficiently and effectively as possible, but also then, following those stepping up goals, reduce future recidivism, enhance the number of connections and type of connections and quality of connections to care, but also breaking that cycle of recidivism and then untreated mental health. I don't know anything about Oregon in particular. So in this case, would it be somebody who's basically they get paid more, or because you can now, is there just a bigger budget? I think, Lauren, this is your question too.
I'm not sure. That was actually for Adrian. Just that, like, alienist in Oregon, essentially. So I mean, this week I heard, I can't even remember what the number was, but just an insane amount, because I mean, people just don't get paid for these evals. But I'm not sure if it was funding or not.
Yeah, because I think that's a really important, like, just the amount of pay also kind of dictates who's actually going to do this, especially if they're going to be independent evaluations. People generally won't be state employees, or state or county. They will be obviously something different. And so the amount of budget, how much it costs to do all those, as well as the actual reimbursement rate, and if it's locally defined, that can be, again, quite challenging. But I think just also like how much money is available to bring more people into that field, even regionally.
Yeah.
Which is not always a county discussion, but it's also always like it's a bandwidth that then takes longer. You also get quality questions probably.
I can jump in really quick and just ask any other counties not from the West Coast, just for some regional variation here to share like any reflections on what Kevin has walked us through, or how does this resonate with you where you sit particularly?
I think California is unique in that it only pursues felony ISTs really. So uh, the folks with misdemeanors are just sicker. So for most states, I just moved from Alabama. I'm now in Virginia. But Alabama, honestly, I kind of think it's because they don't realize that they could actually pursue misdemeanor ISTs, which I think is a good thing, but it's pretty progressive to only pursue felonies for such a conservative state. Um, and so I think the states with misdemeanors are just see even higher rates, and that just the volume is wilder. So it wasn't. I mean, California is a lot more different than Alabama in terms of the services that they're offering. But Alabama's, I feel like, is more similar because it's that felony issue. But in other places, I think it's just a lot higher. The volume's worse. People are sicker. So most people, it's harder to stabilize them, to do outpatient restoration, or even stay in the jail. They're getting triaged to the hospital. So
One thing on the misdemeanor, and I think that's also been a recent thing, because I'll see people that are spending quite a bit of time on whether they're the rate, I mean, the number of years they might spend in custody for the crime itself. And I think that becomes like the disconnect. Like, have you seen other states kind of start to move away from misdemeanors or look for alternatives? I do agree there's going to be sicker. And that's kind of why they're such a wide group of untreated, usually lower level issues. But then does that ever pop into become a felony, or is that, I think that's also kind of rare in my experience. Most misdemeanors don't become felonies, so to speak.
yeah.
That's,
Texas started decriminalizing little baby steps. I think their next step might be like urinating in public or something like that. But just thinking about some of those quality of life offenses that folks that are really sick, that, Starbucks won't let them in anymore because they scare people, so they don't have anywhere to go to the bathroom, or some of that kind of like trespass, criminal mischief stuff, they're starting to, I don't know if decriminalize is the right word, but just acknowledging that that's contributing to their wait list because they're over 2,000 people.
and I think that was part of what, when I kind of looked at the underlying crimes for some of these as well, like the variation, and this is only, again, one state, handful of counties, is really was you did see kind of that, like what the type of actually underlying offense. And I guess with felonies, it obviously becomes much more specific upstream, but a lot of them were that same flavor of like assaults that if you read behind it, could have been maybe intervened differently with. And I think it really was like, how do we kind of define what that public safety risk part of it is versus what are the things that really are criminogenic risks, which are just like better socialization, cognition issues, and education support. And I think that was the part where, I think we're trying to go to now, at least in some of the counties I work with, is like, how do we kind of think about not just the treatment part, but also the underlying, what's kind of keeping them in these kind of patterns for themselves beyond just the, getting medication or getting on a treatment regime.
Mm-hmm.
So, I'm from Lucas County, Ohio, and so Ohio has kind of recently, you're talking a little bit about the difference between misdemeanor and felony. We kind of have eliminated some options for individuals charged with misdemeanors instead of felonies in terms of restoration and to a space at our state hospitals. So we have like a dismiss and refer process whereby if you have a misdemeanor and you're found incompetent to stand trial, they'll try and dismiss your charges and send you out to probate court. But so one of the problems that we've had with this new process is that we don't have good connections to treatment for individuals that are charged with misdemeanors. So you almost sometimes wish people were charged with felonies because at least then they would get treatment. So I wanted to thank you for this toolkit because I think we've been in this place where we've been trying to identify like what the problem is and whose fault the problem is. And I think that these spreadsheets and tools that you've put together will help be more solution focused and less focused on whose fault or who's to blame for certain things, because as we all know, that's just never productive. So thank you. I really appreciate this.
But I'm glad that's the message of this too, is like, it's nobody, if we're a collective and a collaborative, it's nobody's fault. It's how do we do better together? And I think, this comes from that idea that you're humbly asking, why is this happening? And not blaming the housing consortium for not having enough housing or some other part of this not doing something. It's really more about how do we just make priorities and then work towards them consistently. And just, that being we're always trying to do better over the long term, not this week or this month. But I'm glad that kind of showed through. That was the philosophy behind this. How do we prioritize together, not just make up things or blame other people? And Jacqueline, thank you for that note too. That's okay. And I think this program's like that on the front end, like that's a great example. Like a lead program can help with just that cycling of people, or that the interactions in the community before there's like if there's a different way to de-escalate a situation, and also engage people that are those higher frequency or more using county services. How do we kind of use that on the front end and not just wait for them to have an inpatient placement or some kind of more serious crime? So I think all those things, the way that I kind of think about it, just all these things that lead up to it. There's two things that are inside the process and then come after the process. And if we can kind of break down which ones we're focusing on, this is kind of why the competency process kind of lends itself to that. If you have better crisis response, you can really maybe change the trajectory of some of these cases or some of these people's days or lives. And then also in it, how to make it the most effective and efficient. But then after it, how do we make sure we're connecting folks to services? So I think the lead program is a good example, like a precursor to that. I did have a question actually for Lauren, as a follow-up. I'll read your paper because I'm always interested in these like cross-state ones. But did you ever risk not just the volume but actually of time? Because one thing I think from some of the federal standards, like nobody really has a good sense of time. That even though we're all talking about it, everything should take a certain amount of time. Every state has different standards, and some have no standard for how long restoration should take. I was wondering if you had seen anything like that.
Yeah, actually, in June, we sent Freedom of Information Act requests to all states because PRA had a great, like, huge document in January, February, I think, with like statutes, review, and psychology, public policy, and law had one also this spring. But statute is not the same as administrative guidelines, and most statutes don't have those numbers. So we were interested in those administrative pieces because every state should have one. I mean, most of them do have some kind of internal process. And is there a standardized risk assessment when if cases are dismissed, or they're committed after being found not restorable. So I can send that to you. I know one of my research assistants was making an Excel sheet of it. We don't have everywhere because a lot of places said that's administrative. That doesn't count as Freedom of Information Act request because that's a decision model or something like that. But yeah, so still incomplete everywhere.
Yeah. Well, the reason I mentioned that, because I think the only two things that, without going too deep into any one state's regulations or penal codes or, administrative codes, is that really there's two national standards that, and this is probably a simplification, and maybe I'm not as up to date as I should be, but between Dusky and Jackson, really about what is it and how long should it take? Really the only two things that really are in federal law in any way that I know of. Then you have this wide variation in the details. And so but that's just my exposure to it. But I was wondering if you'd seen anything else, but it doesn't sound like much has happened since the 70s.
I think a lot of places don't have those Jackson criteria. It's what is reasonable. So that means something different. I worked in the federal system for a little bit, and I was surprised when I got there that it was actually like a year that they would go ahead and pull the trigger on someone getting Jackson and found not restorable. Whereas it could go a lot longer in other places, especially without those like administrative guidelines. So it's pretty sad.
Thank you. Well, I think without other questions around, and just thanks for the kind of I think the national perspective on this. I think because there is so many, even though we're trying to have some of the national conversation, like there are 3,000 plus conversations. So I always appreciate that. How do you kind of go between the local to the national and then in between with the states? So as kind of I think all the docs I have are already in the chat, I think, and I think these get sent out as well afterwards. But yeah, happy to, again, take them as they are. Like if they're useful, that's the intention. And hopefully they're just make for a better local conversation.
Great. And thank you everyone for joining today. And Kevin, thank you again for providing your expertise on this topic. Just a reminder, we are recording this session, so this recording will be available about a week from today on the web event page. We're also going to send a survey after the session just to get your impressions on the event today and suggestions for future training and resource opportunities at the Justice Center. So if there are no other questions, thank you everyone for joining and have a great afternoon.